I have the pleasure of being part of this Vancouver Island panel. I've got two dietitian colleagues of mine here for a really neat talk that they've titled, "Is There Anything Left to Eat? Diet Guidelines from Chronic Kidney Disease, Non-Dialysis to Dialysis." I think it's a fantastic topic. We're going to be hearing from Jennifer first, and I have the privilege of working with Jennifer in the Kidney Care Clinic, and she's been part of that clinic for 9 years. She's worked previously in diabetes, neurology, surgery, GI. She's got a rich background. And one of the things that our patients often complain about is, when there's comorbidities, well, what's left to eat? I'm not supposed to eat this, I'm not supposed to eat that. And I love this practical approach that's brought in with the renal dietitians to tell people what they can eat, that these are not always mutually exclusive diets. It's a nice message. After we hear from Jennifer, we're going to hear from Eileen. I think everybody here knows Eileen. She's a member of our planning committee, and she's become a fixture at the BC Kidney Days meeting. We're going to talk about diet modifications that can delay progression and help manage symptoms of chronic kidney disease. So please welcome our two dietitians, Jennifer and Eileen. Thank you.
Okay, so this presentation is going to be divided in two parts. The first part will be the pre-dialysis diet, and the second part, the hemodialysis diet. So this is Joe BC Kidney Day. He has stage 4 CKD with high potassium and high phosphorus levels. So the goals. So when I meet Joe, depending on his blood work, his symptoms, his diet history, and some other factors, we'll discuss what his nutrition goals are and move forward with the nutrition plan. So initially in the diet appointment, we'll focus our attention normally on these 4 key nutrients. There's other conditions that we have to consider, such as gout, diabetes, hyperlipidemia, reflux, even malabsorption conditions. And fortunately, Joe only has a few of these conditions, but for the sake of simplicity and the interest of time, I'm just going to keep to these 4 nutrients. Oopsie. There we are. All right, so protein intake. So the recommendation for protein for this patient is about 0.75 to 8 grams. 0.8 grams per kilo per body weight. This is not very much of a restriction. I consider it more like a controlled protein diet than versus a low protein diet, just because it's not that less than what we would recommend for a healthy individual. So some of the considerations that we think about when we're looking at protein requirements for the patient, we also have to think about factors that increase needs. So surgery, ulcers, malabsorption would increase their needs. Symptoms such as meat aversions would impact the amount of protein that they're able to consume, and also the type of protein, so animal versus plant-based protein. And research is revealing there's a difference on the impact of the type of protein on renal health, and I'll talk about this later on. So this is Joe's 3-day food record, and the highlighted items are his protein-rich foods. So I look at this, get a lot of information on quantity, and I've assessed that he has about 8.5 to 7 ounces, up to even 9 ounces of protein per day. So Joe's clearly exceeding his protein requirements. And so I need to think about knowing ahead of time that he has to reduce his potassium as well as phosphorus. I'm going to try to focus on high protein foods that also contain potassium and phosphorus. So some examples are dairy products, some meat, chicken, fish are all high in potassium as well as phosphorus. Now, Joe's already consuming 1.5 to 2 ounces of his daily requirements of protein from milk alone. So he's been eating like this for many, many years. And with discussion with Joe, discussing some of the options he can do to reduce his protein intake, I've learned that he's not ready to change a lot of things. So I have to respect his readiness for change, and we have come up with a plan to reduce the milk for 1 cup a day and just focus on the protein at dinner time. And then as we work together, we can reevaluate his protein intake and learn other ways to further address the other areas. So phosphorus, the daily recommendation is 800 milligrams per day. So the amount and type of protein can influence phosphorus intake. So I already spoke about protein amount. So if we automatically reduce the protein intake, we're going to affect the phosphorus load that the patient's taking. And now the type of protein. So there's 3 points around here. The first point is that plant-based phosphorus is not well absorbed by the body. So although it may contain, for instance, this 1 cup of kidney beans, it contains 186 milligrams of phosphorus, but only 93 milligrams is absorbed by the body. So that's something that we consider about plant-based proteins. The other piece is that plant-based proteins have less potassium and less protein, as you can see with the comparison. So we have to carefully choose our plant-based protein. The kidney beans here are canned, they're drained, and they're rinsed really well to remove some of the potassium. So you can see the difference is quite significant there. And the other piece about the plant-based protein is that research is showing that it tends to increase bicarbonate levels, which is a positive thing for our kidney patients, as well as it tends to reduce the fibroblast growth factor 23, which is involved with phosphorus metabolism and vitamin D enzyme activity. So when we reduce the FGF23, that has a beneficial impact because high levels of FGF23 is very harmful for kidney patients and is even suggested as a risk factor for death. So I'm sure more stuff is going to come out in research on this. So a poll, so get ready. Knowing that Joe is consuming a lot more protein than he needs, and the protein sources are high in phosphorus, how much phosphorus do you think Joe's taking? A, B, C, or D? We've got some dietitians in the audience. It's the C, 1,200 right now, 1,200 to 1,500 milligrams. Now, the other area of the diet when we're looking at phosphorus is the additives. It's abundant in our food system, unfortunately. It must be listed in the ingredient list, but not in the nutrition facts table. And in the ingredient list, it doesn't have to be listed in any particular order, so not from highest to lowest. So anywhere in the ingredient list may not necessarily reflect the concentration of phosphorus in that food item. Phosphorus additives can increase the amount of intake of phosphorus, total phosphorus, by 600 to 1,000 milligrams a day. So Joe could actually be consuming 2,000 to 2,500 milligrams of phosphorus per day by way of the phosphorus additives. So we can also see that phosphorus additives are often compounded with sodium, so that's another factor that increases the total amount of sodium in that particular food. And at the bottom there, you can see phosphorus being compounded with potassium. So that's another concerning nutrient that we're finding more and more in the food system. So here's an example of Subway's version of an oven chicken roasted sandwich. And you can see in red the phosphorus additives there. And that's without the sauce and cheese, which also could have phosphorus additives in it as well. So what can Joe eat? Well, here are some fast food choices that are low or have no phosphorus additives, and out of all the other menu items that these companies have, they're the lowest in sodium. So there's a few things here. And at home, we can look at Joe's menu that he's currently having, and we could say instead of having the ham, you might want to use leftover fresh chicken breast or cooked chicken breast. You can have fish. You maybe want to make a stir fry. Maybe make a burrito using some beans as suggestions for him. So using very practical suggestions so that he can integrate these easily. So sodium, we all know well that sodium has a negative impact on blood pressure, heart health. We also know about edema, but a lot of our patients, I think, at least in my practice, are not familiar with the relationship between proteinuria and sodium. And so I try to tell my patients this, so sometimes it's very motivating for them to know that not only does it help the blood pressure, but it can help reduce the proteinuria, and we know that's a risk factor for progression. And also enhances the effectiveness of those medications that are used for that reason. So, the Subway chicken sub, we're just going to look at some sodium content. If you make it into a wrap, it's 1,200 milligrams of sodium, so more than half the day's daily requirements. We have a Tim Hortons innocent breakfast sandwich. There's no ham, there's no bacon or sausage or anything like that, and it comes in at 610, which is not too bad. But then if we take a better look at the egg omelet, it's not just a few eggs. These are the ingredients of the egg omelet. And I got this from the website. Anybody can look it up, and you can see salt is riddled through, so it's not as innocent as it looks. And if somebody just wants a grilled cheese panini sandwich, thinking it's very simple, just cheese and bread, well, that comes in at 1,530 because they use processed cheese. So I want to help Joe learn how to read labels, how to make good food choices, and get him to understand what he's putting in his body, and also have the choice to control, a bit of control in his life. So the potassium bit, I'm just going to talk really briefly about this. Again, potassium is found abundantly in protein foods. So again, if we're reducing the amount of protein, we're going to reduce the amount of potassium load. Other foods that he has, well, I spoke about milk. Milk is very rich in potassium. It has 350 up to 400 milligrams of potassium. And if somebody has to watch their intake to keep it to 2,000 to 3,000 milligrams per day, it contributes quite a bit. So I might also look at other foods that he continually has on a regular basis, such as bananas, avocado, and looking at some other foods that he can make substitutions for. And I focus my attention on foods that he likes that are also low in potassium, and tell him, well, these foods you can have, and use substitutions within them. And as his kidney disease progresses, he's going to need more advanced restriction, and I'll let Eileen talk a bit more about that. Potassium additives, this is getting into the food system already. You saw in the phosphorus additives. I went on to Health Canada's website and I started counting how many potassium additives were approved in Canada, and I came up and I stopped at 14, and there was so much more. Here's an example of potassium lactate in just a wiener, and it provides an additional 155 milligrams of potassium, so that's very significant. Unfortunately, at this time, in this case, they don't have to put it on the nutrition facts table, but they have to do it in the ingredient list. When the company decides to make their food low sodium and they use potassium salts instead of sodium chloride, they must put it on the ingredient list and in the nutrition facts table. So here's an example. We have the baby dill pickles. We've actually added the potassium on the nutrition facts table just to illustrate here. It has 37 milligrams natural occurring, and then they use potassium chloride to reduce the amount of sodium. They slash it in half, but then they increase the potassium up to 190 milligrams. So in my practice, I would tell the patient, go ahead, enjoy your regular dill pickle. And this can happen in ketchups and soups, so it's very concerning. Yeah, thanks. So the last little bit is some resources that I'll use for Joe and his wife. There's the davita.com. It's an American-based website that I find very helpful with menu ideas. And then there's the Canada's, the Foundation's website. They have a kidney community kitchen, and I find this website is very good, but it's quite dialysis focused, so it's helpful for those people on dialysis. The last bit here is just the 9-part video that dietitians of BC have created, and it's a great tool, I find. And then on the public domain of the agency's website, they have the diet handouts. And then those that are liking to use their apps, we have some great apps here, and then I just came across a couple other ones from the National Kidney Foundation on managing gout and My Food Coach, which I'll want to explore soon. So now Joe is transitioning to hemodialysis, and his nutrition care will be taken over by Eileen.
Now that Joe is starting dialysis, he's going to meet a whole new care team. I'll be his dietitian in the hemodialysis unit. Diet guidelines are designed for Joe based on his nutritional status, his appetite, blood work, and dialysis prescription. Joe tells me that he hasn't been feeling well lately, and in the last 4 months, he's lost about 10 kilograms. Transitioning to hemodialysis will make him feel better, but it will also result in some really significant changes to his diet. Joe's goals for diet therapy are different than mine. He just wants his food to taste good. It's my job to help him find ways to eat food that he likes and still meet my goals around weight, potassium, phosphorus, sodium, and fluid intake. During our first visit, I asked Joe about what he usually eats, who prepares meals, and if there's any financial barriers to having enough food to eat. Joe loves to cook, but he hasn't been doing much cooking lately and has resorted to having canned soups, deli meats and sandwiches, and meals that are just easier to make. Norma, his wife, is willing to do some of the cooking, but she needs recipe ideas. And fortunately, there are no financial issues affecting their food intake. A quick look at his diet recall shows me where there are places that Joe could reduce his intake of sodium and fluids, potassium, and of phosphorus. Even though Joe has spent time with Jennifer, he still finds the hemodialysis diet pretty overwhelming. It's really too bad that everything starts with a P. I start out by reviewing basic renal diet guidelines, and these will be adjusted over time. And while doing this, I assess what Joe already knows and where he needs more information. Protein is the cornerstone of the dialysis diet. Joe needs to eat more protein than he did before he started dialysis. This change causes a trickle-down effect on the rest of his diet. Joe's estimated protein requirement is 83 to 97 grams a day, which translates into 7 to 8 ounces of meat, fish, eggs, or poultry. I provide this handout which explains the basic information about protein choices. Joe and Norma are encouraged to cook fresh, unprocessed, no salt added protein choices. There's also a group of high protein foods that are higher in phosphorus. Joe will learn more about these when we talk about phosphorus. Due to poor appetite and weight loss, due to poor appetite and nausea, Joe hasn't been eating enough protein or energy. And so I ask him to supplement his diet with 1 bottle of Nepro a day. Nepro is a nutrition supplement that's formulated specifically for people on dialysis. And while it's lower in phosphorus and potassium than other nutrition supplements, it still contains phosphorus, potassium, and fluids, so it can't be considered a free food. The financial cost of this supplement is covered by the Provincial Renal Agency, and the indication for its use is reassessed regularly. Joe needs to limit his phosphorus intake to less than 1,000 milligrams a day. This is really challenging because, as Jennifer said, protein foods contain phosphorus. The protein that Joe needs to eat uses up 3/4 of his phosphorus allowance. And there's phosphorus in other foods too, and it adds up quickly. The information in the yellow box at the top of this page describes some of the changes that Joe needs to make to reduce his phosphorus intake. Cutting back from 1 cup to a 1/2 cup of milk will mean that Joe's going to have to give up his glass of milk at supper time. Other high phosphorus foods need to be limited to 2 to 3 servings a week. Many of these foods are protein-rich foods, including peanut butter, cheese, and legumes. Joe has been prescribed Tums as a phosphate binder, but when I ask him whether or not he takes them, he says he only uses them if he has an upset stomach. Many people are confused about Tums, so I explain why they've been prescribed and that they should be taken with his meals. Sorry, I forgot this side of the page. There's the milk choices. To replace the milk that he so loves, I suggest that he try a milk substitute for cooking on his cereal in the morning and as a beverage within his fluid allowance. These products vary a bit in nutrient composition, so the dietitian will suggest the one that's best for each patient, and I've suggested that Joe try either the rice dream or the coconut dream. Norma asks whether or not canned coconut milk and coconut water would be a good substitute for these milk replacements, but I explain they're not the same thing and that they're actually very high in potassium and need to be avoided. The third P on the list is potassium. In addition to food choices, urine output, body size, dialysis prescription, medications, and medical conditions all influence serum potassium levels. The protein food that Joe needs to eat uses up about half of his potassium allowance, and most of the remaining potassium in his diet will come from fruits and vegetables. Joe had a high potassium level, so it's important that he understand what foods are very high in potassium so that he can avoid them. We do review the high potassium foods, but we focus on the foods that are lower in potassium that he likes and that he can eat. Potassium restriction is about eating the right kind of food in the right amount. I ask Joe to limit his servings of fruits to 3 servings in a day, and the serving size is half a cup. The green box on the left side is a list of lower potassium fruits that Joe can choose from. Joe and Norma are reminded, though, that a half a cup of grapes is 12 or 14 grapes, not the whole bunch, and that a half a cup of apple is closer to half a small apple than eating the whole piece of fruit. It's all about portion size. A couple of strawberries sliced on top of Joe's cereal is a low potassium choice. But if he increases his serving size or has extra servings, he can get into trouble. I asked Joe to limit his vegetables to 3 servings of half a cup each. Once again, the green box on the left lists many lower potassium vegetables. Just remember, the whole cauliflower or the whole bunch of carrots is a lot more than half a cup. Directions for double boiling potato are also explained. Cooking potato in this way removes enough potassium that potatoes can safely be eaten in half-cup portions as one vegetable choice. With Jennifer's help, Joe has cut way back on his salt or sodium intake. But recently, Joe has been eating commercial soups, which add up to 1,000 milligrams per serving. Norma and I talk about recipe ideas for low-sodium soups that Joe can have within his fluid restrictions. This is an example of a tasty low-sodium soup that's easy to make using no salt-added beef broth that's available commercially. I encourage Joe to spice up his meals by adding low-sodium seasonings. He's surprised to learn that fresh lemon juice will improve the flavor of many foods, even his steak. The final P is for fluids. Joe doesn't make any urine, and as a result, he needs to limit his fluids to about 1,000 mils a day. That's 4 cups, and a cup is 8 ounces, or 250 mils. So the audience poll question is to tell me if you know how much Joe's Tim Hortons coffee holds that he has every morning. So it's a large cup. You guys are very smart. So the answer is C, it's 2.5 cups. So I'm hoping that Joe is thinking about ordering an extra small coffee tomorrow. The first step to limiting fluid intake is to limit salt. Asking someone who's eating salty food not to drink is like asking them not to breathe. Once sodium is managed, there's other ideas, and they're listed on this form, to give people some support in limiting their fluid intake. Joe has decided that he's going to suck on ice cubes instead of drinking water, and that's a great idea. He just needs to remember that 1 cup of ice melts down into 3/4 of a cup of water. So Joe and I talk about the changes that he needs to make and review a sample meal plan. Norma just wants help with recipes, so I give her a few copies of Spice It Up and refer her to their website. I also suggest that they look at the cookbook, Kidney Friendly Cooking. Joe and I are going to be meeting regularly, and he'll have a chance to ask me questions, and we'll make adjustments to his diet guidelines. This brings me to the end of our presentation, and we'd welcome your questions at this time.
Thank you very much. We have a couple questions here texted in. Are there any live questions to entertain first? I think in the interest of time, I'll read on. This is one actually that I would like answered as well. Do food allowances, like the size, portion sizes, vary with patients according to patient size?
Oh, that's a yes and no answer. So absolutely, Joe's protein requirement is dependent on his body size, and we assess that based on his ideal body weight with some adjustments for extra weight if he's overweight. Potassium allowance is certainly affected a bit by body size, but also by urine output. And so the potassium allowance may be very different if a person is making 2 liters of urine or somebody who is not making any urine at all. So those are the best answers I have. Yeah, okay.
Okay. Another question is, how much value should we place on telehealth nutrition consults between visits to support patients in their goals?
Well, I haven't had any experience with telehealth.
I think if we're using, I know I use the telephone a lot. If we're using telehealth, I mean, if the people are remote, that again, some contact is better than having no contact, and so being able to respond to questions in a timely manner is really important to people, and being able to lead them in the right direction instead of them getting their information from people who don't understand renal nutrition and who aren't dietitians, I think is valuable no matter, it's a lot better to have a contact by telehealth than to not have the contact at all.
One other question here. What are your recommendations for patients who travel more than 25% of the time for business and dine in restaurants?
I have a patient like that. It's really hard to try to support them. We can, look at options of takeout foods and what foods would be best for them, but we try to focus on just if he can go to the grocery store and even get food to go, that might be more natural, like so some of the sandwiches, egg salad sandwich, or some items that we know are available that are convenient for them. So try to give them some information around that, and then there's some apps that they can use that I find helpful for different restaurants that they can use for sodium and potassium, and if they know the obvious of eliminating or avoiding potatoes and using salad and different rice as different substitutions, and I try to focus on that, as well as looking at the whole diet. So it's a whole diet piece, so it's just 25%, the other 75% we can focus our attention on looking at the diet a little bit at home.
Great. It is time, but I'm going to be selfish because I think this is an important advocacy question. I'm really concerned to see these potassium salt additives and products working their way in, and whenever I counsel patients, I tell them about the product called no salt or half salt, because I've had a couple patients that reach for that thinking they're doing the right thing. So I wonder if this is a message that we should be getting out to food producers, certainly to patients, but even on a public health level, this strikes me as very dangerous.
Jennifer's been involved with some lobbies through Dietitians of Canada, so she might
Yeah, I've had some contact over the last couple years about potassium and even just getting it on the label. So in 5 years, it'll be mandatory for all products to have potassium content. So that would include any content from potassium additives. So that could help guide, but certainly it is a concern about getting the approval. And so anytime that I get these notifications that this product has been approved for to be added, my blood boils, and I make contact with the advocate at Dietitians of Canada and talk about the needs of our patients, and even people who don't have renal disease but have medications that increase their potassium. So they need to know, although potassium is great for those that don't have blood pressure and we need more potassium and less sodium, it's not always so positive. So I'm trying to work on that. But at least we're making headway of getting it on the nutrition label, and phosphorus is just another story.
It sounds like a slow process then, and I think we do have some advocacy work to do, so maybe we'll have more on that later. Great, thanks so much.
Thank you.